Today, I'm going to be supporting Midwest Health Connect and Celatura HIE Core by discussing the Center for Medicare and Medicaid Services, or CMS, Conditions of Participation, or COP, for admissions, discharge, and transfer notifications, or as we like to call them, ADT messages. I know that other states tend to refer to ADT messages as encounter notifications or ENS, so just know that we're really trying to speak to the same type of message. And so as you can see, I'm going to be abbreviating just a little bit today just because things do tend to get very wordy on this topic. So I have outlined the abbreviations on these slides, but please feel free to ask questions in the chat box if things begin to get confusing, and I can go ahead and answer some of those. And then just one more thing before I move on is I just want to point out that I will be co-presenting today with Angie Bass, who I'm sure all of you are very familiar with. She leads things over at Midwest Health Connect and will be really adding in valuable content on how MHC can support the hospital and the PCP and PAC community. So Angie, please feel free to sprinkle in content if you think I'm missing anything or if you want to add on to what I'm discussing. So with that, we can go ahead and get started. So just to kick things off, I want to start with the authority that CMS has to create the conditions of participation for ADT messages. At a very high level, conditions of participation are federal regulations with which particular healthcare facilities must comply in order to receive Medicare and Medicaid dollars. So if you really want to zoom out and see how these regulations come to be, what typically will happen is Congress will release a law giving a federal agency like CMS the ability to write up regulations for a particular area. CMS will then release a reg that will place specific requirements on healthcare entities participating in Medicare or Medicaid. And an always great motivator to get entities to comply really quickly is to tie those requirements to funding. And so that's why it's going to be such a crucial part of public health and how these entities are really going to be able to receive dollars to support their populations and their communities. Now, the COPs that we're going to be discussing today address one specific part of the CMS final interoperability rule, which requires Medicare and Medicaid participating hospitals to send ADT messages to establish post-acute care and primary care providers for a patient. But we're going to be going into a lot more detail on how exactly that will work. So the COPs were released early last year, and since that time, we've played an active role in really trying to unpack the content in them and ensure that we're compliant. So as a part of our analysis, we compared all of the requirements to our encounter notification service or alerts. We reviewed any guidance from CMS if there was ambiguity in the language. We determined how this would affect our hospital stakeholders and brainstormed how we could support them in meeting these requirements. And then we even went one step further to consult with other entities on a national basis to determine how others were really understanding these requirements to ensure that we weren't missing the mark on any area. So I just wanted to give that background before we moved on, just to emphasize that we have had our eyes on this throughout, even though this webinar is coming a little bit closer to the compliance period. So in the next few slides, I'm going to go through content that's going to be the most pertinent to the hospital community and really speak to the actual requirements and language and the conditions of participation. The first basic question is going to be, who do the COPs apply to? And for the ADT requirement, it's only going to apply to Medicare and Medicaid participating hospitals, which are inclusive of psychiatric hospitals and critical access hospitals, and that's just for now. What is interesting, though, is that CMS has now narrowed the scope a bit to state that this requirement is really only going to be imposed on hospitals who actually have the capacity to generate the basic patient, personal, or demographic information needed for electronic event notifications, and that's usually done through an EHR. So again, just something to keep in mind when it comes to applicability, particularly if you are a smaller hospital. Now, if you are a hospital that's going to be subject to the COPs, you have to meet the requirements set out in them, and that includes being fully operational and compliant with the federal rules for health information sharing, being able to use the content exchange standard necessary, being able to send the minimum patient information, which I'm going to go over in the next slide, and then lastly, being able to send notifications through an intermediary. And when I say intermediary, think of someone like a health information exchange or a health information network that's ultimately going to facilitate exchange of health information to a wide range of recipients on a hospital's behalf. So a really great example of an intermediary would be Midwest Health Connect. So as I mentioned before, minimum patient information must be sent, and that's going to include a patient's basic personal or demographic information, the name of the sending institution, and the patient's diagnosis, so long as the sharing of that diagnosis is available and it's not going to be restricted by state or federal law. And just because these are the minimum requirements, that's not to say that entities can't share more information, but the purpose of these COPs are really just to set that baseline for ADTs so that some of those organizations who are not currently sending them at all can really begin to do so and comply with the requirements. And I think that that's why it has such few pieces of information right here at the beginning. Now, when it comes to how information must be sent, the COPs don't go into great detail there either. They merely state that the hospital system must be able to either send directly or through an intermediary. Again, think of like an HIE or an HIN. But the second part of this requirement becomes important because they begin to go into who should receive the notification and for what purposes. And that's going to be to providers, patient care team members, and post-acute care providers and suppliers who are going to receive the notification either for treatment, care coordination, or quality. So very in line with like HIPAA TPO. For individuals or entities that have an established care relationship with the patient. And third, for individuals or entities that the hospital has reasonable certainty can receive the message. And that's something that could even be determined during onboarding or something like that. And just to expand a little bit more on the last point of to whom ADT messages should be sent, they need to send the notification to those individuals or entities who are in a way almost entitled to receive it. And this is actually going to place an affirmative duty on the hospital to ensure that their system can send the notification to the patient's primary care provider, the patient's primary care practice group, or really any other practitioner, practice group, or entity that has been identified by the patient as someone who needs to have that information. Now, before I wrap things up on just the general requirement side, I just kind of want to bring it back to how these requirements are going to impact primary care providers and post-acute care providers that want to begin to receive ADT messages from hospitals. And I think that there are a few ways that MHC can really help to support that effort. So one way that MHC may be able to support this is by providing an easier onboarding process for smaller PCPs and PACs. So for example, one thing that we have seen in Michigan that has been a huge value add has been moving our data sharing agreements online so that organizations can click a link from our webpage, scroll through the agreements, kind of like a terms of service, and click accept to begin receiving ADT messages and really begin receiving content in a matter of days. The reason why this was so crucial for us is before our legal onboarding process used to take months in order to just come to an agreement with all of our healthcare stakeholders. So by having the agreements online for review, organizations or primary care providers or post-acute care providers can really easily go on there, review at their own pace, and then click agree on their own time frame. Another area where MHC may be able to provide some support is really by determining how ADT messages are sent to us and which ones may be sent to us and not reach its final endpoint. So I covered this a little more probably on the slide before than on this one, but perhaps MHC could engage in an effort to determine why those messages ultimately aren't reaching its final destinations. That could be due to something like inaccurate delivery preferences or maybe outdated delivery preferences that PCPs or PACs have provided to us. And so maybe through an efforts like community outreach, we can reach out to a range of providers from across the state and make sure that we have their most up-to-date delivery preferences in our system so that not only are we receiving ADTs from hospitals, but they're actually reaching the endpoints and getting to the primary care physicians and providers that can ultimately coordinate their care. So MHC, as I mentioned, has been out ahead of this initiative for quite a while, and they are able to provide a few different resources to also support their stakeholders. So I know that they have template policies that their stakeholders can use, templates for compliance plans, as well as tailored consulting services. And I know that I have gone through a lot of just the high-level content thus far, but it might be a good idea right now to maybe turn it over to Angie, and I know that Jackie Porter also joined from the MHC side, just so they can kind of speak to other ways that MHC might be able to support its stakeholders, or other things that MHC might be doing right now in order to help with some of these more high-level compliance efforts.
Yeah, thanks, Shreya. Thanks for everybody joining today, and many of you know that this is just one of many webinars we've held over the last year, so I appreciate the time and the attendance today. We have been providing support and services related to coming into compliance with this COP. And so we have template information blocking policies and HIPAA policies that we can offer to you to put in place. We have legal consulting services to help you actually do a compliance assessment that is very robust and takes through all the work streams that you have internally through your HIM department, how to receive requests, how to utilize MHC as your central point to facilitate information requests, both receipt of the request for information as well as sending out from an information blocking standpoint. But we also have opportunities for in regards to the CMS COP rule to make sure that you know that MHC is facilitating the service on behalf of the hospitals and able to send out ADT messages to the non-acute community. And how we do that, I want to make sure that we give some time to Jackie to kind of walk us through how we are doing that. But at a high level, for all of our hospitals currently that we receive ADTs from, which is 99% of them, we are facilitating this on your behalf at no additional cost and sending it out to the community. So whether it's the primary care or the specialist or to another hospital, we have a process for that. We also have a certification form that we are able to provide to you that can be used with CMS to attest to the fact that you have met this COP obligation. And so we will be offering that on or before May 1st, which is the compliance plan. So for the hospitals listening today, and we can get that to you out within the next 30 days for sure. Jackie, let me turn it over to you just to quickly give everyone an overview of how we are technically accomplishing meeting this reg for the hospitals on the sending. Are you there?
Okay, can you hear me now?
Yes.
Okay, so as most of you probably know, your project managers, Chris and Chris, have been in contact with all of you regarding adding your PCP and your MPI numbers to your ADT in order for us to know when the patient does identify a PCP that they want an alert to go out to. So those things have already been put in place for most of our participants. They are already sending that information. We're continuing to work with a few that have not started supplying that yet. But once we start having all of that information flowing, we are working with a few to start sending test ADT messages for the alerts to the selected, I would say, PCP on their side that is willing to test with us to make sure that the alerts are flowing like they expect. Once we know that those are flowing, we will work with each organization to make sure that we have the right direct addresses if we don't already know for the PCPs and how they want to receive those alerts. Some of them, I will say, are trying to figure out on their side if they want the alerts to flow directly into the provider's direct account, or if they are wanting them to go into more of a care management or a shared mailbox. They're a little concerned with the alert fatigue that some of the providers could be facing with all of these alerts. So we are working with each one of our organizations to figure out what works best on their side from the workflow standpoint. If it is not a PCP that we currently provide our direct secure messaging for, we are working to map and pull down the national NPI registry, because the direct addresses are being populated into that registry now. So that if the PCP is not part of our internal network, or we don't necessarily have a direct address for that provider already on our side, we can map that out and send those alerts out to them based upon what is in the registry. So if you have not contacted MHC about who at your organization either wants to receive them, or if you want to send them to a shared account, you can either reach out to myself or Chris, or we will just base it off of what you have put into the MPI registry. Angie, was there anything else that you wanted me to cover from that standpoint?
Nope, I think that's good. Just encourage folks to ask questions along the way or put it in the chat.
So it looks like Melissa did have a question about the behavioral health provider. So we can send it to the behavioral health provider if the patient has identified that behavioral health provider as the PCP. It will all be based upon what the patient themselves says and identifies as the PCP on their side.
So can it have, I'm sorry, this is Melissa. Can it have more than one like alert? So can one go to like a behavioral health provider and then another to a PCP, or is it just strictly one or the other?
So most of the ADTs that we have been receiving only have one or the other. They do not typically include two. In terms of providers, they really stick with the PCP only. So it's all based off of what they include in the ADT.
Okay, thank you.
Okay, Shreya, you want to keep us moving?
Yeah, I think that this is actually just going to be an open Q&A portion. So if anyone has any questions, feel free to post them in the chat, and then myself, Angie, and Jackie can answer those. And that includes questions on content and the actual conditions of participation, as well as MHC's response. I know that Angie kind of mentioned it from her side, but we do have a few materials that we're able to provide if anyone has any questions, and that includes like a frequently asked questions. We had it available from the hospital perspective, but we recently just created one for primary care providers, post-acute care providers as well, just so they could more easily understand how they can begin to receive and really use those ADT messages for care coordination. But yeah, I'm just taking a look now at the chat box just to see if anyone has any other questions for us.
Yeah, I think, and we'll make that document available as well, and send that out to the group. I think one of the things that we are conscious of, rather, maybe a better word, is the hospitals are now required to start sending a lot of alerts. And for those of you who already receive alerts from MHC pre-CMS COP, you understand and know that we put a lot of filters on ADT alerts so that you're only being alerted for the things that you have indicated are a priority for you, which is different than now the hospitals just have to flood the community with every admit or discharge. And so what we really want to focus on as you as a MHC participant, as a receiver of those ADTs, whether you're a hospital receiving it from another hospital or a non-acute facility receiving it from a hospital, we're very conscious of not only can you receive the ADT messages, but what do you want to receive all of them? Do you have capacity to sort through all of it? Do you want us to put any additional filters on them so that it, you don't get alert fatigue? And how can we help you prioritize that process? Do you and so really encourage you to reach out to us and continue the activities that I know are already underway to help you through that process of being a receiver of these ADT messages. It's very easy to get alert fatigue, and it's great that this is now a CMS regulation because there's great value in making it a requirement. But you do have to have process and people, frankly, on the other side to get the value out of it. And workflow, as always, is a huge consideration and factor. And then deriving the value out of the message is something that we certainly want to help you to do. So I think the takeaway message here is certainly there is an obligation on the hospitals to send out this stuff, but hospitals and non-hospitals have to have a plan for being in receipt of these messages and what will you do with them when you get them. And that's what we're here for. So please let us be of service to you in that capacity. Shreya, you want to keep us moving?
That sounds good. I know that there was also one question on compliance timeline for the conditions of participation. The compliance deadline is actually May 1st of this year, so it is coming up quite quickly. But like I said, what is always worth it for hospitals to take a look at is the actual language of the conditions of participation. I've provided some of it in this PowerPoint template, but I've also done a crosswalk of each requirement that came out of the COPs. And it is important to understand what the requirements actually are, and then compare that to what other things MHC is able to provide in addition, and how they actually provide an even more valuable service to its participants, because just the requirements in the COPs are going to be very, very bare minimum and kind of the baseline that you need to receive any sort of encounter notification. However, just like Angie said, when you start to think past just the requirements and what is actually going to be helpful in terms of care coordination, that's when I think a lot of those questions are going to start to come up from hospitals and providers on which ADTs do they ultimately want to receive, and for what time period, and what format do they want to receive them in, and some of those other components. So definitely happy to speak more to that if anyone has any questions. Other than that, I think that we've kind of gone through the deck from my end. So Katie, I'm not sure if you wanted to keep it open for a few more minutes or just have us hang out in this area just in case anyone else wanted to ask more pointed questions to Angie and I, but always happy to stay on for a little bit longer.
Great, yes, I can absolutely keep it open.
Shreya, do you want to expand on that as far as the crosswalk? Anything else you can offer, or that'd be great. I think that would be very helpful for this audience.
Yeah, actually, I'm going to see if I can even go ahead and maybe share out what that crosswalk looks like for attendees. So just give me 1 minute just to pull this up.
And while you're doing that, you know, one of the things that we want to make sure that it's clear for, is as the HIE that's facilitating this within our HIE community and membership, is that we very much want to make sure we're sending these alerts out to the people that need to get them. And, you know, we realize that not everyone is connected to us, so we have a lot of great participation. And so part of this is an outreach effort. And if there is a group, a provider in particular that you as a hospital want to make sure that we are getting ADT messages to, then part of our job is to help with that outreach to make sure we're getting them the ability to receive the message. And whether that's through our alerting service or through the direct message, whichever way is sort of the cleanest, quickest path to victory, there is what we're here to do. So if in your compliance evaluation, you determine a certain organization or provider to fit within your, we have to get messages to this provider, and they're not currently a member of MHC, that's not an obstacle that we can't overcome. So we just let us know, and we can work to make sure that we're getting the messages to them. Certainly, if they've got a direct secure messaging address already, we can provide we can look them up in the directory, and we can facilitate that. So that's part of our job. So just wanted to make sure that that was very clear also.
Thanks, Angie. I did pull up the crosswalk that I was explaining to you all. What you're going to see as I start to scroll through it is a lot of the language that is in the PowerPoint presentation is direct language from the conditions of participation itself. But what's really interesting is upon reading through that content, you're going to see that there are much fewer conditions of participation requirements than there are sections where CMS is merely just giving guidance on how a hospital could feasibly meet this requirement, but it's not really something that says you must send an ADT message in X, Y, or Z format, and you must send, you know, in this time period, and you must connect to an HIE that's connected to this number of participants. I think what is really going to be a big takeaway from the conditions of participation is they're not necessarily saying that all of the hospitals need to have a perfect ADT solution in place. What they are trying to say is if you are a hospital that has EHR capabilities in order to generate that minimum patient information and you have the capability to send it, now is the time to begin to send that information. And that's going to be very in line with the information blocking rule compliance period that's coming up in just a couple of weeks here, and a lot of other interoperability efforts that are also going to be in their compliance periods this year. So MHC is kind of a leader in this space and kind of at the forefront of leading these interoperability efforts. So if you're connected to MHC, you're probably very, very well situated to maximize your compliance. But this crosswalk really helps to identify what the actual COP requirements are, what additional guidance CMS has given on those components. And then on the side here, we have like a checked box or a checked, box to show compliance, and then just a check mark just to show alignment with the CMS guidance as well. And that's really just to acknowledge that not only is MHC compliant with some of those basic requirements, but in addition, when CMS is a little more forward-looking in its guidance and says this might constitute best practices or this may be a great thing for a hospital to have in the future, MHC is also able to meet some of those guidance components that CMS outlines. And I won't go through every single box here just because it is quite a few pages long. As Katie said, we're going to release a recording of this presentation as well as the slide deck tomorrow. I'll make sure that everyone also has this crosswalk if you wanted to take a deeper dive. But one thing that I do want to do is kind of show you how the minimum requirements are going to stop pretty close to the top here, but the guidance keeps going for quite a bit longer, for a few more pages. And that is just because, exactly like I said, they gave a lot of ideas to the hospital community to say, this is a potential method that you could use, or this could be used to show reasonable effort, and some of those other things. So, again, this is just another resource that we want to be able to provide for you all, but please feel free to reach out via email if you have any questions, and we're happy to answer those as we receive them.
Thanks, Shreya. And then I did just want to make sure that you saw there was a question that was in the chat, if you haven't already addressed that.
So if they do not use an HIE, then do they need to use an HL7V 2.5.1 message? No. First of all, this initiative does not require participation in an HIE framework. However, they basically say that HIEs can be used as intermediaries in order to meet that reasonable effort standard of care under the conditions of participation. So usually if a hospital or a provider is connected to a health information exchange, they already are participating in some sort of encounter notification services use case. And I believe that that is why CMS pointed to HIEs and HINs so much in this piece of regulations, is just because they realize that that may be a really good way for hospitals to comply, as if they're not already engaged in, let's say, their regional or statewide health information exchange. They could become connected and begin sending and or receiving messages that way. That being said, when it comes to the actual format as well, the COP said that there is not a standard format that hospitals have to use in order to send those messages. They can really use whatever format they're currently using or whichever one is feasible. That being said, like MHC is kind of at the forefront, so they probably are not only able to send just through their HIE framework, but they also are probably able to accommodate some alternatives to get those messages to providers, like direct secure messaging inboxes and other avenues like that. So there's not going to be a yes answer on either of those questions. They don't need to connect to the HIE in order to receive the message, and it doesn't need to be in that particular format. Although if they're participating in an HIE, all the messages might be sent in and received in one standard format.
Does anybody else have a burning question in their pocket? Is anyone feeling anxious about meeting the deadline that we are supporting? Good, good. Okay. Well, we don't need to belabor the point. We wanted to just make sure we provided an educational opportunity, as we know we are butting up against the May 1st deadline, to make sure that we were attentive and responsive. And so we appreciate everybody's time and attention today. We're available if you need us for any additional questions or information. But I think if no one has anything else, we're happy to give you a few minutes back. Shreya, any closing comments?
Oh, sorry to jump in here, Angie. There looked like there was one other question that came through about what is CMS feed when your patient does not know PCP feedback.
What is the patient does not know PCP?
Angie, I can maybe kick off an answer to this, and feel free to add anything that you think that I may miss. I think the question is, what's CMS's feedback for when the patient doesn't know who their PCP is? So
yes, I think you're correct. They did say the CMS response.
Okay, yeah. So one component of the requirements of the conditions of participation is that hospitals really only have an obligation to send these ADT notifications to established primary care providers and post-acute care providers. And that can be done through a few different formats. So for example, it might be done through like a provider patient attribution service where providers are saying, here is my list of patients. And then like a health information exchange or a health information network can do a lookup of that patient to see who all of their care team members are and then route to them accordingly. So that's one way that you're able to kind of establish a provider relationship. And then another way, which is a little more simple, is either the patient or the primary care provider themselves can actually communicate to the hospital that I would like to receive ADT notifications for a particular patient. But if that patient is unaware of who their primary care provider is, unfortunately, the hospital would not have the responsibility of determining that on their own and maybe sending to them, unless, of course, there is that provider patient attribution service in place with that HIE. And Angie, maybe you can speak to the way that that works in Missouri.
Right. So I'll speak to it generally, and then Jackie will fill in the details. Essentially, we are just matching the patient to whoever we have a patient relationship with, which is why we are ensuring that all of our participants are including the PCP in the ADT messages, so that when we see that an admit or a discharge is happening at a hospital and Clinic A or FQHC or specialist has a treatment relationship with that patient, we're automatically just going to send out the notice to that provider whom we know has a relationship with the patient. So generally that's how it's working, and just so that we cover all of our bases essentially. But that's also why we want to make sure that you, as the receiver of that alert, have a way to deal with the traffic that's coming. So Jackie, anything to add?
No, that's exactly right.
So just a quick example then would be if a patient is seen at St. Genevieve Memorial Hospital and they're discharged from there, but that patient has also been seen at in St. Louis at the BJC Mercy or SSM or ESSA Health, then we would also send the alert to those providers, acute and non-acute, because we know that they had a relationship there based on our master patient index. So and the PCP relationship that's denoted in the ADT. So that's just a quick example of how that would work. And really that approach, just to add a little bit more, was to take the burden off of you of specifically what do you do in that scenario of if you don't know the PCP or they can't remember the name and you have this obligation, you can just know and understand that we have that covered as far as we know, because as I interpret the rule as you have to use your best efforts to send it out to the community in which who needs to receive the alert. In this case, using the HIE is incredibly valuable because we've got the largest swath of potential providers that need to know who that message, ADT message, needs to go to. Did I miss any other questions? I think that's good.
Thanks, Angie. And I think you covered everything. So I think that I'm also good from my end, unless there are any other questions, Katie.
Nope, not at this time.
Very good. All right. Well, everyone, thanks so much for your time. We appreciate it. If you do have any follow-up questions, of course, we're available. Just reach out to Jackie or myself or your project managers, and we're happy to help. So thanks so much, and happy to give you 18 minutes back.
Thanks, everyone.
Bye.
Thank you. Bye.